Hello, everyone, and welcome to Apt Associates Black History Month webinar series. I'm Joanne Germain, the overall chair for Black at Apt, Apt Associates Black Employee Networking Group, and today I have the pleasure of introducing our wonderful speaker, Dr. Yvette Cozier, on her talk, Stress and Health, Data from the Black Women's Health Study. Dr. Cozier is an associate professor of epidemiology and the associate dean of diversity, equity, inclusion, and justice at Boston University's School of Public Health. She is also a senior epidemiologist at the Sloan Epidemiology Center at Boston University School of Medicine, where she is the MPI for the Black Women's Health Study, a prospective follow-up of over 59,000 African American women that began in 1995. As a social epidemiologist, Dr. Cozier's overall research focus is on the influence of psychosocial and structural factors, including racism and neighborhood socioeconomic status, on health. She has also published on factors related to the development of cardiometabolic and immune-mediated conditions such as obesity, sarcoidosis, and lupus. Additional research interests of hers include the roles of attitudes about spirituality and religiosity on health. And with that, I turn it over to our wonderful speaker, Dr. Cozier.
Thank you so much for that introduction, and thank you for the invitation to present to you today. I'm going to be talking about stress and health, but in particular, I'll be talking about psychosocial stress. And this includes measures of perceived racism, neighborhood segregation, and the conditions that are created by both. First, I'd like to begin with the land acknowledgement. I'm coming to you today from Massachusetts, which is the home of several tribes, Native American tribes, including the Wampanoag, Nipmuc, and Massachusetts tribes. And I find it is very important to acknowledge the land on which I stand, and given my history as a Black woman in this country. I'd like to also acknowledge our research team. So the Black Women's Health Study is housed primarily and administratively at the Sloan Epidemiology Center within Boston University School of Medicine. We have our colleagues and co-investigators, co-directors at Georgetown Lombardi Cancer Center. Years ago when the study began, they were at Howard University. The three founding investigators of the study were Lynn Rosenberg, Julie Palmer, and Lucille Adams Campbell. And you can see the rest of our team at the respective institutions. I also want to acknowledge funding sources. It's always important. The Black Women's Health Study is a study primarily of cancer, breast cancer in particular. So our main funder for both our infrastructure and science comes from the National Cancer Institute. However, I will be presenting on data collected under NCI and other mechanisms as we study many factors within the study. And we're also funded by a host of foundations. So just as a very brief idea of the structure of the talk, I'm going to start with a historic perspective that will really kind of bleed into the overview of the Black Women's Health Study. From there, I'll present data on some of the measures of stress, both interpersonal and institutional racism. Also talking a bit about how we cope with stress and how that changes the trajectory of some of our outcomes. And then I'll swing back to coping again with some data from our studies of religiosity and spirituality within Black Women's Health Study, and I'll end with some future directions. So this cartoon came out in 1995, excuse me, about the same time that the study began. And it's not ever become something that I feel I can retire. So as you can see, it's a Black woman asking her doctor, what's wrong with her? And his response is simply, you're not a white male. And that's because of the way medicine and research has been structured, has focused primarily on white male subjects, to the extent that it was always believed that white males were the stand-in for everyone else, including white women. And that was found not to be the case. When they began studying white women, they believed that they would be the stand-in for all other women. And we know that that is also not the case. So we always have to defend this notion of why we need a study specifically of Black women in this country. But to really understand the health of Black women, we really have to go back historically. We have many different immigration trajectories on this call within this country, but really where the inequitable structures began was when the first Africans arrived on this continent. This is a graphic from Clayton and Bird's two-volume series, An American Health Dilemma, Race, Medicine, and Healthcare in the United States through 2000. And you can see the many milestones during the history of this country, including when the first medical school, the first Black medical college was opened, Howard University, all the way up through the passage of the Civil Rights and desegregation of hospitals under the Medicaid-Medicare Act in 1965. But one of the things that I like to always point when I show this to my students is the actual time. So as we're in Black History Month, we know everything gets compacted into these 28 days. When we were students in textbooks, it's compacted into probably fewer than 28 pages. It starts with slavery and it ends with Martin Luther King, and then nothing happened in between and nothing has needed to change since. But if you look at this timeline, you can see the real impact that an institution like slavery had on shaping this country. Slavery occurred for almost a quarter of a millennia, 246 years. That's a very long time. Many generations were born into that process, and further still, there were many structures that were built to continue that, or to have those generations born into that same condition for that period of time. When slavery ended, officially, it did not lead to complete freedom or really any freedom. For the next 99 years, we had, a crippling Jim Crow segregation, something that is still not well taught in our schools. So it really was not until the 1964 Civil Rights Act. And even that act fell short because it required the Voting Rights Act that came in 1965 that actually granted full citizenship to African Americans under the law. So if we go back to the Civil Rights Act, 1964, to today, it's only been 58 years. It's only been 58 years for African Americans having full citizenship under the law, and we can argue as to whether that has been a reality or not. So it's within this context that health has been shaped. And what we knew in 1995 when the study began was that Black women had higher risk of disease and death, for higher, sometimes 2 to 3 times at minimum higher than white women for disease or death from almost every major illness. Yet there were no efforts to truly study the why. So when the study began, the goal was to establish a way of studying the why of this. We want to know what diseases exist, the rate in which they become known, which is incidence, and to really quantify and measure risk factors. Again, the study was primarily funded for breast cancer, but also for other illnesses. To do this, we followed the model that had been used for other studies of large populations, mostly white and male. This way we would establish this cohort and follow them forward into time to understand how they individuals went from health to poor health or maintained their good health. So in 1995, we purchased a portion of the Essence mailing list and mailed a 16-page unsolicited questionnaire to lots of women. I believe about 400,000 questionnaires were sent out. Another 50,000 were sent out to those who were recommended by the early responders. We also included the National Black Teachers Association, the Black Nurses Association, and other professional groups. At the end, about 59,000 women who completed the questionnaire and fell between the ages of 21 and 69. So this was the cohort that has been followed ever since. That first questionnaire asked basic demographic questions, lifestyle questions, questions about the medical history at that time. And every 2 years since, we've updated with follow-up questionnaires. So the 2021 cycle now is the 13th follow-up questionnaire that has been sent. Of those women who completed that questionnaire, that at the time in 1995, their median age was 38. They represented all regions of the United States, and they had completed at least 80% had completed some education beyond high school. So again, every 2-year questionnaire cycle, we update information, and we also ask about conditions and as hypotheses emerge. So for example, in 1997, we added the first questions on psychosocial stress, racism, stress, or trauma. In recent years, as the cohort has aged, we've added additional questions on oral health, in particular tooth loss, and also memory and cognition. So this current questionnaire, it focused on a lot on COVID. In addition to the other questions that we routinely asked, we asked a series of questions regarding COVID. I'll also say that and in 2020, we did obtain some additional funding from the American Heart Association to ask a supplemental questionnaire. So we approached about 20,000 women who had completed the questionnaire online and offered an online questionnaire about their COVID experiences. But we also wanted to extend this to the women who had not completed their questionnaire online. So you can see we asked questions like, do they believe they had COVID, how they were diagnosed, the severity of their symptoms, and even, if they had planned to get a vaccine. So these are analyses that are, or data that's still being collected and analyses that are ongoing. Over the course of the study, we link to other data sources, both to enhance the information that we've collected. So cancer registry and Medicare data are ways to validate what participants report, but also to be made aware of new cases of disease within our cohort. We follow up vitality through the National Death Index. This is a deposit of all of the death records reported to registrars across the United States. So we're able to follow and be notified when a participant has passed away. We also can link to the Census Bureau, link address data to learn about the neighborhoods where our participants live and functions about and features of the built environment. Green space is a big measure these days. Also, location in proximity to commerce and roadways. And through census data, you can also link to the Environmental Protection Agency to get an idea of environmental exposures such as air pollution and even noise pollution. We've also collected biological data over these 27 years, starting with saliva samples, getting DNA from the buccal cells within the mouth, and also getting a sample of the bacteria that lives there. And so there's been a lot of interest in the oral microbiome and how that promotes health or provides risk for disease. We've collected blood samples for breast cancers and other tumors. We've obtained samples of tumor tissue blocks and slides. And my colleague Kim Bertrand is putting together a image repository of mammograms as she studies mammographic density as a risk factor in detecting breast cancer. So it's also important to stay in touch with our participants, right? So over the years, we mail reminder letters. The questionnaire is offered online for those who prefer to submit their contributions that way. We maintain a Facebook page. Every 6 months, we mail newsletters, keeping participants up to date as to study findings and study progress. And we have a participant advisory group. They are women who, within the study, that we can turn to and say, we want to put this specific question on the next questionnaire. What do you think about this? How would you want us to go about asking or studying these other conditions? So there's always a way for the participants to be involved beyond simply providing questionnaire data. So we've collected quite a few conditions over time. These are diseases that were present at the beginning of the study, as well as diseases that women have been diagnosed with over the course of the study. So this is quite an exhaustive list. And in reality, we've been able to study, to some degree, a smaller list, but still we have looked at quite a few conditions. Our full publication list is available on our website. The web address is here, but you can see that among cancers, we've looked at breast primarily, but we've looked at other cancers. And we study quite a few non-cancer, but chronic conditions. As was mentioned in my intro, I study sarcoidosis and lupus and other conditions that are on this list. So I want to turn now to some of the analyses we've done in response to changing norms in our culture over time, and trying to capture the stressors that not only occur frequently, but are unfortunately staples in the lives of Black women. And these are experiences of racism. So, when we thought 2020 was a tough year, 2021 just said, hold my drink, I'll up you here. And so we've had quite a bit of stress over these last few years, but we know that these things have started long before then. So back in 1997, working with Dr. Kamara Jones, who I understand presented with you last year, we asked a series of questions on the Black Women's Health Study questionnaire. One, race consciousness. How often do you think about your race? Everyday racism and lifetime racism that were measures developed by Dr. David Williams, who is at Harvard University. And so really in your day-to-day life, how often do any of the following happen to you? You receive poor service in other people. People act as if they think you're not intelligent. People act as if they are afraid of you. People act as if they think you're dishonest or that they're better than you. And then for lifetime racism, which is a bit more structural, but these are things that happen over the lifetime. Have you, ever been treated unfairly due to your race in obtaining a job, getting housing, or encounters with police. So again, these were posed in 1997. So here I'm showing some data that Dr. Jones published using Black Women's Health Study data, and it's based on some of the analyses that she and I had done on another endeavor. But I think this particular layout is important. So at the top, you see that the response of the Black Women's Health Study. At the time that this analysis was done, 49,000 women had answered this question. By the time our final analyses were done, about 53,000 had answered this question, but the results are pretty much the same. But you can see that at the top is the Black Women's Health Study. Just below them are the Black nurses who were part of the Nurses' Health Study, another large cohort of similarly aged women. Obviously, they're nurses, so they had a professional affiliation. The majority of them were white, but they did have some women of color. So we have about 1,300 Black nurses. You can see here in the middle, the white nurses, so 88,000 of them. There's about 1,500 Asian women who are nurses, and about 1,200 Hispanic or Latinx nurses. And just from a view, you can see that the responses to this question vary quite a bit according to race. The Black women in the BWHS and the Black nurses are almost identical, even though these are women in two separate studies, two separate populations being asked the same question. You could see at the white nurses in the middle, whose responses shift in entirely the other direction, right? They are like 4 to 5 times as likely to say they never thought about their race, right? While the Black women are, like 20 times as likely to say that they constantly think about their race. If you look at the Asian women and the Hispanic women below them, they're somewhere in between. They're half as likely to report never thinking about their race, right? But they're also more likely than the white women, but less likely than the Black women to report thinking about their race on a constant basis. So this just really gives a frame of the lived realities that women have, because we're talking about women's health here. The lived realities that they have according to their race. So when we try to look and understand where racial disparities occur, we really have to look at this as well, right? A lot of the conversation sometimes is around access. Do we have the same access to healthcare? Do we have same access to education and all of these? The Black women in our study were well educated. 80% had education beyond high school. The nurses represent a similar demographic. Some of them have masters and doctorates, but some of them are also, have 2-year nursing degrees, maybe an LPN who has, less coming out of high school. So we're talking about similar demographics, but different lived experiences. And this is really where I find great interest in trying to interrogate the sources of health disparities. So we've done a number of studies looking at some of these questions, moving away from the how often do you think about your race, but really getting into the other questions that are the everyday and lifetime racism. And we've seen associations with preterm birth, with hypertension, with risk of breast cancer, gynecological conditions like uterine fibroids, weight gain and obesity, which then is also a risk factor for type 2 diabetes and other respiratory conditions like asthma. More recently, we've looked at the effect of perceived racism on sleep. So we'd updated these questions in 2009, and at that we'd also included some questions from the Insomnia Severity Index, which participants could answer on their own. And the higher the frequency of reported experiences of everyday racism or lifetime racism, had a higher risk of women who fell into that sort of, troubled sleep, but not full insomnia, but also for those women who met the criteria for clinical insomnia. So they would be women who you would have to engage in behavioral therapy modification, perhaps medication, in order to get a full night of restful sleep. And, these weren't caused at all by shift work and other things that could disrupt your sleep. We've also recently looked at risk for cognitive decline as the population gets older. But of course, among this sample was in 17,000 of our participants who were aged 55 and older, and 55 is not that old, right? But we were able to, within that same age group, if the women who reported higher levels of these discriminatory events also had or showed a higher risk of cognitive decline. So the way they performed tasks, their memory, ability to continue a conversation, things like that, those things were being impaired. And again, this is at a relatively young age 55 and older. So it's also important that we think about how is it that we cope with stress. Okay, so we have these stresses, what do we do with it? Why are some people more affected than others? We don't have all of those questions, but how the individual processes the exposure, if you will, the stimulus has some to do with that. And that's called coping. So in 2005, we put the Carver Mini Cope, as it's called, instrument on the Black Women's Health Study Questionnaire. And this asks about how do you cope with stress? Do you try to do something about the situation, get support from other people, try to see it in a different light, twist it so that it seems positive, just accept the reality that this happened, and or learn to live with it. All of these are a little bit different in shaping how we process the events that happen in our lives. So we did an analysis where we were looking at weight change over an 8-year period in relation to or in response to these experiences of racism. And if you look on the left side of your screen, in response to the everyday racism questions, we divided the women according to how they reported they coped with stress. So the blue line are those women who scored low on that previous instrument. So they were the ones who accepted it as a fact of life, just took it and didn't think they could do anything about it. While those in the red were the women who were a bit more proactive, tried to do something about it, talk to other people about it, tried to put it into some context. And what you can see here, this is weight change in kilograms. So when they say mean weight change, some women could have gained weight, some women could have lost weight, but this is just the average. But overall, you see that there is a weight gain for both groups over an 8-year period. But those in the blue, those who had the worst coping, gained the most weight. We can see something similar, although it's a little bit closer together. The interval is much smaller. for those in response to lifetime racism. Those with the blue with the low coping gained more weight over the 8-year period than did those who were more active in their coping. So coping is important. We asked another set of questions on coping a few years later on, again, sort of pulling out those elements. This was an instrument by Nancy Krieger, who's at Harvard. So if you've been treated unfairly due to your race, do you accept it as a fact of life or do something about it? Or do you talk to other people about it or keep it to yourself? So we were curious to see how this played out. And we did a different analysis this time. This analysis was looking at telomere length. So just as a quick, little primer, telomeres are the caps that you find on the ends of your chromosomes. They're like the plastic caps at the ends of shoelaces, and they're there to basically preserve the shoelace, right? These are here to preserve the chromosome. We know with the shoelaces, over time, that little plastic wears away and the shoelace will slowly start to unravel. Well, our chromosomes do the same thing, and to an extent, and telomere length can be a measure of biological aging, chronological aging. As we get older, our telomeres diminish. So some studies have found that extreme stress has an effect on how quickly those telomeres diminish. So we looked at this in about 1,000 women for whom we had blood data and DNA, and we were able to measure their telomeres. And we basically found an inverse association. That is, the women who reported higher rates of racism actually had shorter telomeres than those who did not, but particularly among those who said that they internalized their situations, they kept it to themselves, they accepted it as a fact of life, their telomeres were even shorter. Okay, so again, coping affects the body in many ways, and it actually even works its way down to the genetic level. So now I want to switch a little bit to structural racism. We've talked a lot about that in the news, and it's thinking about, not so much the interpersonal experiences, but really the structures, the policies, the sort of embedded pieces of our lives that function in a restrictive way without any of us having to think about it, because they're built that way to maintain a dominant group. And the way that I study structural racism the most is through neighborhoods. I'm fascinated about the places that people live because they have such an important role in our daily life. The physical environment, whether it's an aesthetically pleasing place, a noisy place, the social environment, who our neighbors are, who we get to know and meet, who we invite into our homes, whose homes we go into, the resources that are available. This is where you hear people saying, well, I moved here because of the schools. I did this because of the schools, or because of this or that. These are things that, are available to us primarily at the neighborhood level. And all of those things affect how we seek healthcare, how we go about taking care of ourselves. Can we walk in our neighborhood? Can we exercise in our neighborhood? Do we do it alone? Do we do it in groups? And perhaps there's, the local school provides the facilities for the community to engage in. What we also know in this country is that neighborhoods differ significantly by racial composition. So this was a quote from back in the 1990s from Robert Sampson and William Julius Wilson, where that racial difference, that in, the largest cities in the US, there isn't a single city where whites and blacks live in ecological equality in terms of poverty rates or rates of single parent households. And then the worst urban context in which whites reside is considerably better than that of the average context of Black communities. So basically, there's very little overlap, and communities differ significantly in terms of race. So unfortunately, my animation didn't quite work on this one, but zip code, right, has emerged as the best predictor of your health above and beyond what your genes might indicate. And if you were able to see the image on the bottom, the top here represents a community that is primarily African American, while the blue represents a community that is primarily white. And you have this big road, sometimes it's a major avenue, sometimes it's a highway, that separates the two. And this top image here that I put on was that what you see below is reflective of policies that were in place, and we can argue are still in place, but what we talk about is redlining, okay? Assigning neighborhoods a grade in which they were considered desirable or not, where you were able to obtain a loan for housing or not, and that even as we claim that redlining has ended, the fact is the structures and vestiges remain, so that we still see these very segregated neighborhoods. So here we're looking at census geography. So I mentioned the census before. We can get data from the census every 10 years, and in the interceding years, the census is consistently and constantly collecting data, and it does so, and it breaks it down according to geographic areas. So, thinking you have, within our country, we're broken into states, and states are broken into counties and cities. And within cities, we have these areas called census tracts that have about, up to 8,000 or so people. But then we have block groups that can be about 3,000 to 5,000 people. And we were interested in getting information at the block group because we wanted to characterize the communities where our participants lived in the most objective way that we could. So some of the data that we got that's available through the census is median housing value, household income, white collar employed, households that have assets, the percentage of adults who graduated college or graduated high school, who are employed, unemployed, households headed by a single female parent, and percent African American or Black, which is a really kind of a crude shortcut for measuring area level segregation. So within our analyses, we have seen that housing value was related to hypertension. So pretty much the lower the area housing value, the higher the risk of hypertension. The overall neighborhood score, we bring many of these variables together to estimate the neighborhood socioeconomic status. So the lower the neighborhood SES, higher the incident type 2 diabetes. Even finding that weight gain, again, over time, as well as incident obesity. So going from a BMI of below 30 to a BMI of greater than 30 within a 10-year period happens more frequently at neighborhoods that are low resourced. We were even able to see the effects of neighborhood in blood levels, blood biomarker levels. So women who lived in the lowest resourced neighborhoods actually had higher rates of the bad cholesterol, the low density lipoprotein. They had higher levels of stress proteins in their blood, and they also had higher hemoglobin A1C, which is a measure of glucose control. So it indicated that they had poor control of their blood sugar. And we even see that there was a risk of mortality due to all causes, living in a lower resource neighborhood than in a higher resource neighborhood. We were able to look at breastfeeding and according to experiences of racism, but I included it in this part of the presentation because of what the results showed us. And what we know, again, is that the rates of breastfeeding among Black women are considerably lower than that of their white and Hispanic counterparts. And breastfeeding is an important function. It has health benefits for both the mother and the child. So looking at some of these predictors, what was it that seemed to predict lower breastfeeding? One was racism in the job setting, which makes sense. You know, if you have a workplace that is not supportive of breastfeeding, you're less likely to breastfeed when you have to return to work. But also, if they're outright hostile to you, you're probably, you know, you're just not even going to deal with that stress, right? So that's a reason that you would like not even start breastfeeding. But here in the middle, most importantly, living in a segregated neighborhood, in a lower resourced neighborhood, has effects on the decision whether or not to breastfeed. And it could be because maybe other women around you aren't breastfeeding either. But this just prompts the need for further study, and we are doing some analyses looking at specific neighborhood details to try to understand this phenomena a bit more. Just recently, one of our doctoral students completed her doctoral studies, and this was one of her papers. And she found specifically around breast cancer that living in a low SES neighborhood increased the risk of ER negative or triple negative breast cancer. Now, these are the breast cancers that are harder to treat. And unfortunately, Black women have a higher likelihood of being diagnosed with these types of cancers. Several things can have been found to predict these types of breast cancers, and one of them is breastfeeding. We found in a previous analysis of BWHS data that any level of breastfeeding was lowered the risk or was protective against these very aggressive, harder to treat breast cancers. So again, there's health benefits that for both the mother and the child, but we are seeing that there are structures that are contributing to the lower rates of breastfeeding. And this leads to, or has certainly contributed to women who, when diagnosed, because the tumor doesn't have these receptors on it, the receptors are what help make therapy more effective, because they're targeted at these receptors. So if the tumor lacks the receptors, the tools that can treat the breast cancer are far less effective. And in terms of neighborhood, I just want to end on this part, air pollution. Again, I mentioned we can also link to Environmental Protection Agency data. And this gives us an idea, a sense of air quality, among other things, in the communities where our participants live. So particulate matter 2.5 microns is one of the more dangerous parts of air pollution, that 2.5 micron is the size of the particle. And because it's so small, that when we inhale, we get a deep inhale, we are actually able to bring in more of those particles deeper into our lungs. So just as context, if it was a 10 micron piece of particulate matter, it might cause us to start coughing. And by coughing, we would then, hopefully eject the particle. We wouldn't be able to take as deep a breath. But with these very small microns, we can take actually a deeper breath and get those further into your body through your lungs. We saw where we had high particulate matter 2.5, we were actually even able to see an increase in hypertension and diabetes, and also nitrogen oxide, which comes off of tailpipes, so it's associated with living close to roadways, also increased hypertension and type 2 diabetes. This is important because here's a little blurb from NPR from just before, or a couple of years ago, just before the COVID, but finding out, recognizing who creates air pollution and who ends up breathing it. Okay, so again, these are some of the structural functions, right? Structural factors that lead to poor health outcomes within communities. So basically, those with money who can, fly overhead, who can order from home, from Amazon and other delivery services, have every single thing delivered, get their groceries delivered. All of that creates a little bit of that, tailpipe exhaust, that people of color are more likely to live near the roadways here, even as they're not contributing to the consumerism that can lead to this additional pollution. They are feeling the effects. Okay, so now I'm just going to quickly wrap up on religiosity and spirituality. This is, again, another type of coping. And we were interested in assessing this in our study. So we'd asked these questions in 2005, but it was many years later that we actually did the analysis. But surveys, external, to the Black Women's Health Study, but national surveys have shown that African Americans are some of the most religious individuals in America. And looking at this series of questions, particularly the one at the bottom, was what was most intriguing to us, or certainly to me. To what extent is your religion or spirituality involved in understanding or dealing with stressful situations in any way? So from not involved at all to very involved. So we were curious about how does religious coping influence health outcomes. We had a couple of separate analyses in which we looked at these questions. And what we have here on the left was an analysis for incident or risk or rate of hypertension occurring. And compared to those women who reported religion was in no way involved in their coping, those who were either somewhat involved, but certainly those who were very involved, showed a decreased risk of developing hypertension over, I think it was a 10-year period. Here on the right, my colleague Tyler Vanderweel led this analysis looking at mortality. And again, compared to those who had no involvement at all, right? You can see that those who were somewhat involved or very involved did show a decreased risk of mortality over a 10-year period as well. So just to just wrap up on that, we are looking, to do additional studies on religiosity. We have collected additional data and are doing so with in collaboration with some other studies where we're pooling our data. So perhaps at a future time, I can talk to you about that, or I can certainly guide you to some of those findings that are for those analyses that are underway. So just to wrap up with future directions, 2020 was our 25th anniversary year. We had hoped to have something in person or, kind of hybrid at the time. And this was before COVID, but then COVID, of course, came. And like everyone else, we went to Zoom. So over the course of 2020 and part of 2021, we hosted some Zoom seminars for our participants and others where we talked about study results. We focused on breast cancer as well as COVID-19 and mental health. And you can go to our website where these have been archived. In terms of future areas of inquiry, some of these were listed on that other slide where I said we have, some of the outcomes we've studied to date. But some of these outcomes are listed here as well because the previous study was really cursory. But here we are actually applying for funding and trying to open up full areas of deep research into these topics. So we've analyzed some data with COVID before, but now we want to be able to look at long COVID over many years. We just, excuse me, recently got funding for start looking at Parkinson's disease, and we have some new grants for stroke and other conditions. So just to conclude, the Black Women's Health Study, the goal has been to be a resource for understanding causes of illness in Black women. We are hoping to continue, so we've just submitted for our 4th or 5th continuance. NIH grants come in about in 5-year increments, so we've submitted our latest continuation, and hopefully we will be funded for additional years of study as we go along. But what we've tried to do over these years, and we hope to continue to do, is to look at not just traditional risk factors, but psychosocial risk factors, similar to what I've shown you today, and also genetic and genomic influences on health within this population. And of course, the reason we do these studies is that others will take the data and try to create interventions that are going to be effective and particular to our community. So that is our goal, and that's what we will continue to do. So with that, I will take your questions, but thank you for your attention, and I look forward to this conversation.
Thank you so much, Dr. Cozier. So we have a few questions. So the first one was asking, what are the retention rate of the participants for this study from 1995?
Yes, we have worked incredibly hard for this. We have an 80 to 85% retention rate for those who are alive. So those who die, we continue to follow up with, obviously. But I mean, so we follow up with them, getting their vital records and, censor their records or their contribution. But of those who are alive, 80 to 85%. And again, that takes a lot of our effort.
And was there any follow-up retrospectively on the participants, and what did that show?
So can you when you say retrospective follow-up, sorry, I just want to be clear. Is there?
So the person who asked that, could y'all clarify that in the chat? I'll just go to the next question. Is there any key questions or sections in the questionnaire or conditions that have been removed over the years, either because of results or feedback from the patient advisory board?
So in terms of removal, um, so there are some questions that we either don't ask or don't ask in the same way. Whenever you're putting together these questionnaires, you have a limited amount of space, right? You literally have like, 2.5, 3 pages to get in all of the things that you want. And you want it to be in a readable format. So some questions I know that we no longer include was marital status. And that was just because, with space, uh, the numbers weren't necessarily changing. We made a decision on that. We may add it again. That's another thing. Sometimes, within a 2-year period, we weren't seeing much changes, but maybe over a 10-year period, we might capture a change. As far as the participant advisory board, um, I cannot recall anything that they asked us to remove, but I do know a question that we asked in 2017 was around trauma and loss. And they, really helped us with this question. And it was whether or not you had lost a parent or guardian due to either just a prolonged absence or death or incarceration, and really, trying to delve more into how that shapes life. So that was something that the participant advisory board certainly weighed in on. And we had the question in there. They agreed that we should have that question, but we had to be very specific with the wording so that people would understand or try to get an understanding what we were asking and not be offended.
So the next one isn't exactly a question, but it's more of a comment that I wonder if you can speak to. So addressing stress or seeking help, um, counseling or seeing a therapist is also disproportionately seeked by race. Um, Cultural norms could also play a role in this. So do you have any insight on that when it came to this study?
Yeah. So, mental health resources like medical resources can often be discordant in terms of provider patient characteristics. So, I'd say that some of the ways in terms of seeking mental health is it doesn't always have to come from a psychiatrist, right? Which would be more the medicalized route. But social workers are also an area of those who are trained in mental health assistance, and you will certainly find more women of color within the ranks of social workers. So sometimes it's being a little creative, but pastors again, church deacons, there can be they can be a little complicated sometimes too, but these are also people who work within the realm of mental health support. So I guess you know the statement, and I do understand it, because if you're whoever you go to, whether they are the same race as you or not, if they don't understand where you're coming from, it's not going to be very helpful, which is often why mental health tends to be neglected in that regard. Sometimes we just don't get the perfect fit. But I encourage people to, find affirmative support somewhere. You never know how, never know where. Maybe it's a friend, it's a group of friends, it's, you know, through church, through other social organizations, wherever you can find community, you know, then I'd say go for it until you're able to find that perfect caregiver for you.
And then the last question we have here is, what is the average age of participants throughout the years?
Yeah, so at baseline, when we started, the median age was 38. So now we're 27 years into it, and I'm doing a quick calculation here, right? That brings us up to like almost an average or a median, right, of about 65 years old. That doesn't mean that they're all 65, it's just that that's exactly, half are below that and half are above that. We began at 21, so again, sorry. Yeah, so the youngest in our cohort would be about 48 years old. And when we began, the oldest was 69. So the oldest in our cohort should be about 96. So about 48 to 96 now.
Interesting. So that is all of our questions for today. Do you have any closing remarks that you want to give before we close out our session today?
Well, let's thank everyone for listening, and I think, just as we're emerging, hopefully, from these last couple of years under COVID, is I think what we've learned more and more is that we are each other's resource. And I'm speaking just from a couple of the last few days. I've been involved in conversations around mental health, and mental health affects physical health. None of these things are separate and siloed. So really, take care of yourselves, take care of each other. And we are each other's resource, each other's community, and we should invest in that. Oh, I see Jasmine Ruffin. Jasmine.